Okay, hello to everybody. It's a pleasure and an honor to be invited to present in this grand round cases. We'll present an interesting case that we have in our trauma service here in Brasilia. It will be about multiple injuries in a blunt abdominal trauma. And to present our case, let me introduce our Dr. Daniela, is our second year general surgery resident. She will perform the presentation, and I will be here in the background. Okay? Daniela, it's okay?
Hi, everybody. Good afternoon. My name is Daniela. I'll be presenting the case today.
It's okay?
Yes.
Everybody see?
Yes, doctor, we can see.
Okay, so today we'll be talking about multiple injuries in the blunt abdominal trauma that happening in our hospital. So to start, we start with the previous contact with the EMS. The mechanism of the trauma was a pedestrian hit by a car in a high-speed road about 10 kilometers from the hospital. There was no apparent external injuries in the patient, but she had several abdominal and pelvic pain. She was sweating with tachycardia, conscious, and agitated. She was with backboard with a cervical collar, and the time between the previous contact and the time they got in the scene was less than 15 minutes. No fluids were administered in the first time. So they got the patient to the Hospital de Base, which is a trauma center for the Distrito Federal. We received the patient in our trauma team. The team leader is always the trauma surgeon. And in this case, the first doctor was the emergency resident, but we also had the first surgeon that was the general surgery resident, the second surgeon, which was the trauma surgery resident. And then we had the leader nurse, the support nurse, and the nurse technician. One stayed in the monitoring and the other one in the venous access. And the physiotherapist stays in the airway support and ventilation. So in our admission in the trauma room, the patient was female with 30 years old. There was no external bleeding. She had a clear airway. She was with cervical collar and without oxygen supply. The expansibility and bilateral breath sounds were okay. She had a 97 saturation, and her respiration rhythm was 20. Her heart beating was 125. She had a blood pressure of 60/40. There was no radial pulse and no IV access, and the pelvic examination was okay, but she had a positive test. The Glasgow Coma scale was 14. She had an isochoric and photoreactive pupils. And in the letter E, she had bruising on her back and left gluteus. So here's the question. What should we do next? Should we go forward immediately to the operating room? Should we go do radiology exams? Should we try to stabilize, or should we start a massive transfusion protocol? What would you guys say?
Okay, so we can start with Dr. Antrak, and I will launch the question for the rest of the audience, okay? So you can make your comments, Dr. Antrak. What would you do?
Yeah. So in this case, you have a patient in shock and lost at least half her blood volume. Positive fast, I assume that the The thoracic portion of the fast was negative, so no pneumothorax or hemothorax. And so you need to get IV access in this case. If you can't get it quickly with peripheral IV, then with sonographic guidance, I would put a cordis introducer either in the femoral vein, or more likely, because the injury is in the abdomen, I would put it in the subclavian or internal jugular vein under ultrasound guidance to speed the procedure. And then at that point, I would give her 2 units of O negative blood while initiating the massive transfusion protocol, and then proceed directly to the operating room. If you gave her 2 units of blood and then her blood pressure came up and her pulse came down and she was stable, at that point you could go to the to a CT or do a secondary survey. But I think in this case, given a systolic blood pressure of 60 and the tachycardia, I would err in favor of getting the IV access, starting the transfusion, proceeding to the operating room. I would limit the amount of crystalloid fluid that I gave her. I'd also give her 2 grams of tranexamic acid, 2 grams of, or depending on her weight, 1 gram or 2 grams of Ancef, and then proceed to the operating room. The other option, if you have it and she's not responding, is to put a Reboa in the through the right common femoral vein and get her stable, and that would buy you a little bit of time to get her up to the operating room and find the cause of the bleeding, get control, and then deflate the Reboa so as to minimize the amount of transfusion that she would need.
Thank you, Dr. Antrak. I see that we have Dr. Calderon. Dr. Calderon, do you have any comments?
Good morning. I'm post-cold, so I'm sorry if I'm a little drowsy. I think Dr. Antrak already said it all. This patient is in profound shock, and she may need to go to the operating room for an exploratory laparotomy. But before moving the patient to the OR, she needs resuscitation. She needs the massive transfusion protocol. At least I would need some quick images like a chest X-ray. I see that she's sitting very well, and clinically the lungs seems to be very well. But I always request a chest X-ray before moving out the patient. The fast is already done and it's positive, and maybe a pelvis X-ray. Yes, I think that's all I have from now. And after the resuscitation, move the patient to the OR. Thank you.
Thank you, Dr. Calderon. Anyone else? Any additional comments that would you like to share? Okay, so Dr. Gusmao, we can go back to you.
Okay. So our conduct was try to stabilize. In the letter A, we start providing oxygen with mask. For letter B, there was no conduct. For letter C, we got venous access, peripheral venous access, a volume expansion with 1,000 milliliters of warm fluid, transamine 1 gram, typing and blood reserve was requested, and at this moment, we did not start massive transfusion protocol. The arterial blood gas was collected. The patient had a pH of 743, a lactate of 368, hemoglobin 9.1, and a basic cells minus 6.6. For letter D, there was no conduct. And for letter E, we removed all the patient clothes and covering, and we didn't see any other injuries other than the bruising in the back and the gluteus.
Estoy tomando matecito acá.
So 10 minutes after the patient arrived, she had an improvement of the hemodynamic parameters. Her heart beating was 90, the blood pressure was 100/70, the saturation was 98, and now she had a palpable radial pulse. She also improved the level of consciousness for a Glasgow 15. but she still had a diffuse abdominal pain. So here we can see that in 10 minutes of like starting the management, we could like change all the patient clinic, just putting oxygen, IV access, the fluids, the blood typing, the blood gas. So she was hemodynamic stable now. So now I'm gonna repeat the question. What should we do next? Should we go forward immediately to the operating room? Should we go to a CT or another exam? Should we start the massive transfusion protocol? What would you guys say now?
Thank you, Dr. Gusmao. Dr. Burke, would you like to make any comment?
Sorry, I missed a fair amount of the presentation, but if the patient, it sounded like she was reasonably stable after the fluid.
I understand.
Anyways, I go on to the radiology exams.
Perfect. Thank you, Dr. Burke. Dr. Antrak, any additional
Yeah,
comments?
yes, no, I agree with that. I would accompany her in case she becomes unstable. And I understand she just got some crystalloid or not blood yet. And if she maintains those parameters, and I think that's okay. And you might need to give her a few start to transfuse blood in the CAT scanner, but be prepared to move precipitously to the operating room if she destabilizes.
Thank you, Doctor. I think we have a question from Dr. Pilasi Menichetti. Doctor, would you like to make any question? I think.
Yeah, sorry. Yeah, sorry. Just my question. Hi, Carlos here from London. My question was like, initially, okay, the situation now changed, and of course now it looks like she's more stable, and probably she could tolerate some X-rays or some CT scan. But when she arrived, was very unstable and in deep shock. So my question was like, why the massive transfusion protocol was not activated by then? Because we didn't know that she would have responded to crystalloids. What are the triggers you use for MTP? Is like ABC or rabbit score, or what are you guys use?
I can respond. Are you listening to me? Hello?
Yes, doctor, we can hear you. We can hear you. Yes. Go ahead.
So in that moment, we do not think about the protocol of massive transfusion, because in the pre-hospital, they didn't make anything. The patient doesn't have an access. They don't make any fluid. So in that moment, when the patient arrives, we did not think to start the protocol of massive transfusion before we start the management. Okay, so we collected arterial blood gas, and we start the fluids to see the response. According to the response, we'll decide for the protocol of massive transfusion or not. So the patient respond for the initial maneuvers. Okay, they arrived from the pre-hospital setting without any procedure. No procedure was made. So we try to stabilize the patient before the start the protocol in about 10 minutes. Okay.
Perfect. Thank you, Dr. Caselli. Dr. Calderon, do you have any comments?
Well, it seems that this patient is responding to the liter of crystalloids, but it doesn't mean that the patient is already safe. So I would keep a close eye to this patient before deciding to move the patient to the CT scan of the OR directly. I see that a base excess is -6, so can be at least a class 3 hemorrhage. If I don't initiate the massive transfusion protocol, at least I would transfuse a couple of packs of red blood cells. And we'll see. Another thing is the availability of the CT scan suite in your emergency department. For example, in my hospital, the CT scan was very close to the emergency, to the trauma shock unit. So with monitoring and with ongoing transfusion, we could take the patient to the CT scan. But if the CT scan is very far from the OR or from the trauma shock unit, that would be very risky. Well, thank you.
Thank you, Doctor.
It's the same in our hospital. The CT scan is inside the emergency department, about 50 meters from our emergency room.
Oh, that's very close. That's good.
Okay.
And when the patient got in the trauma center, the nurse already calls the CT, so it's exclusive for the patient.
Perfect. Thank you. Anyone else? Any other comment? All right, so I guess we can go back to you, Dr. Gusmao.
Okay. So yeah, we decided to go to a CT scan. Now here's the video. I know it's a little bit fast, but I don't know if you guys can see something.
Okay, I control the speed.
Okay.
¿Tenemos una flash?
So does anyone want to say something about the CT?
Dr. Antrak, any comment?
Yeah. So the patient has a ruptured spleen, probably grade 2 or 3, and a non-functioning left kidney without hemorrhage around the kidney. So, and if the patient is still stable at this point, and I agree, Dr. Calderon probably needs some blood. I don't know what the hematocrit was on the blood gas, but I, probably could use a unit or two. Yeah, I'm not sure what the arrows are pointing to. That the kidney is okay, and that hematoma is higher up. That's probably the spleen. So this, anyway, I would get, if you have the interventionalists and if the patient's stable, I would get them involved with first attention to stopping the bleeding so they can coil the spleen, but then see if they can pass a wire in the left renal artery and then do a balloon angioplasty and stent it, whatever they need to do to, you might, in typical Brazilian fashion, like, oh, I'm blanking on the name from, well, Larry, help me out. Not Dr. Collet, but the other center in Brazil.
Dr. Fraga?
Dr. Fraga, Unicamp.
Yeah.
Dr. Fraga, right.
Yes.
His team, he would just have this patient all fixed up and, in fact, discharged by now. So you won't even have to, the patient will won't have any scars, look good on the beach, all that. So I think that's probably what you did.
Thank you, Doctor. Dr. Burke, any comments?
Yeah, my gut reaction would have been to go to the OR after getting a chest and pelvis, but looking at the scan, at least I would agree with Dr. Untrak that if something, I'm assuming the kidney injury is acute, and I'd try and do something with that interventionally as well as with the spleen since you're there.
Thank you, Dr. Burke. Dr. Pilassi, would you like to make any comment?
No, I agree. I just would like to know what the blood pressure and heart rate is at the moment after the CT scan.
The patient remains stable. The blood pressure and the heart ratio was normal. during the
Thank
CT and after the CT.
Perfect, thank you. We have Dr. Neiman who has a question. Dr. Neiman?
Yes, I heard before you were mentioning that the patient had tenderness in her abdominal exam.
Yes.
I think it was maybe possible to take the patient to the CT scanner, but if with these findings and with the peritonitis, the abdominal tenderness, I think taking the patient to the operating room would be safer. She would probably end up with a splenectomy, maybe a nephrectomy, depends on the hematoma appearance, but we cannot rule out bowel injury with such a significant injury. And even if she's not in shock now after treatment, I think she needs to go to the OR.
Thank you, Dr. Neiman. Dr. Calderon?
Yes, I don't have an interventional radiologist at this time in my hospital. I think there is a new guy, but I don't know him yet. Well, with my drowsy eyes, I paid attention of the ruptured spleen, maybe a high grade, and that the left kidney is excluded, maybe a vascular renal injury. And with the peritoneal signs, I would take the patient to the OR for exploratory laparotomy too.
Thank you.
Yes, thank you.
Thank you, Dr. Calderon. Okay, Dr. Gusmao, we go back to you.
Okay. So yeah, the patient, so the radiology report was that she had an extensive areas of laceration, the splenic parenchyma with active bleeding, a moderate hemoperitoneum, signs of damage in the left renal artery with hypocontrast in the parenchyma without significant hematoma or active bleeding, associated with small amount of emetic in the pararenal space. The excretory phase was without extravasation. And the image suggests of traumatic mural hematoma, abdominal aorta at the level of the renal vessels. So in the other CTs, she had a iliac dislocation in the right sacroiliac, a fracture of the right acetabulum misaligned, a fracture of the left iliopubic branch misaligned, a fracture of the left ischiopubic branch, a minor pelvic hematoma. In the other CTs, the cranial, the cervical, lumbar, and spine and chest was without alteration. So in this case, I would repeat the question like, what should we do now? Should we go to a laparotomy or hemodynamic suite? In our hospital, we have angiography and hemodynamic suite, but it's not in the same place as the operating room. It's a little far away. So,
Dr. Burke, would you like to make any comment?
Well, I think I'd probably, if your interventional radiologists are really good, I'd probably, again, try to do the interventional route.
Okay, thank you, Dr. Antrak. Baghdad?
Yeah, so yeah, those are the two options, and it depends on your situation. I know Dr. Fraga, too bad he's not here. I think, you know, if he says I would operate on this patient, then that's what should be done. But I think in this case, I'm guessing he would say this is, you know, stable patient. This is a case he'd be really excited over it. You know, his residents wouldn't get to operate, but you know, it seems to be what he's good at. And here in Iraq, we wouldn't have an option. We'd have to operate. I think the issue, whether there's bowel injury, you know, on the CT, they say the signs you look for is bowel wall thickening and fluid in the peritoneal cavity. In this case, there's blood, there's hematoma, but you don't have free fluid floating around in other places or outside the area of the kidney and the spleen. It's almost all there. And I think, you know, if you decided for the angiographic approach, then you can stop the bleeding, open the kidney, and observe the patient. My guess is that she would get better, and there would be less fluid. You wouldn't have more fluid accumulating or signs of infection, and her lactic acid would improve, and you can follow her clinically if you chose that route. But then if you operated, well, you could take out the spleen, and you can do, it's on the left side. One option would be without a graft, a splenorenal bypass. Take the splenic artery, separate it from it's off the top edge of the pancreas, free it up. It's very mobile. Bring it down and anastomose it to the renal artery distal to the area of the blockage. It seems like there'd be a long length of uninvolved artery, and you don't have to take any vein and don't have to put graft in, and that would be an option, and you can take care of both problems at once. I think either would be appropriate depending on how comfortable you felt, how comfortable your angiographers felt, and the logistics.
Thank you, Dr. Antrak. Dr. Pilassi, would you like to make any comment?
My question was like if the patient was peritonitic or had just mild abdominal pain, because some degree of pain that probably she would have because of the trauma, but which would make me worry is like if she's peritonitic, and we know that CT scan was not showing small bowel or large bowel injury, but we also know that CT is not the greatest to identify those injuries. So if the patient was peritonitic, for me, would need surgery, but would be looking for contamination, therefore would be second priority. Since the patient is stable, I would consider probably a combination of both. If you have the availability for interventional, probably to start with that one, and followed by laparoscopy, diagnostic laparoscopy plus minus laparotomy.
Thank you, Doctor. Dr. Calderon, any comments?
Yes, I would still prefer to take the patient to the operating room for a laparotomy. Yes, I would remove the spleen, most likely. I would still like to take a direct look to the bowel and to the left kidney. And I can do, if I need it, pelvic packing once in the OR. Thank you.
Thank you, Doctor. I see we have Dr. Ramos. Dr. Ramos, would you like to make any comment?
Hello. In our hospital, she would be taken to laparotomy. We don't have angiographic or any type of hemodynamic told this. So that's what we have, laparotomy.
Perfect. Thank you, Dr. Ramos. Anyone else? Any comment? Okay, we go back to you, Doctor.
Okay.
Okay, let me tell you. So we decide for the laparotomy for this patient because three main factors. First of all, the patient is still hemodynamically stable, but we don't know until when she will stay, how long she will stay stable. And the image of the active bleeding in the spleen lead us to the laparotomy, and the abdominal pain was these three factors lead us to decide for the laparotomy for this patient. Okay, let's go.
Okay, so in the laparotomy, we find a moderate amount of blood, about 700 milliliters, a multiple splenic laceration with active bleeding, a 2 centimeter laceration on the antemesenteric board of the jejunum, about 30 centimeters from the trites, a small hematoma in the transverse meso, small, non-expensive, non-pulsative hematoma in zone 2 on the left. So we did the splenectomy and the primary repair of the jejunal injury. During the surgery, 25 minutes from the anesthetic induction, they made replacement with blood and plasma, but the patient remained hemodynamic and metabolic stable during all the procedure. So now what's the next? Should we do the zone 2 hematoma exploration? Should we do a nephrectomy, a damage control? Should we go to the angiography, or just admit the patient in the ICU?
Dr. Antrak, would you like to make the first comment?
Yeah. So, this patient, 30 years old, if you had to, you could take the kidney out, but the patient is stable, and the hematoma is not expanding, but the kidney's not functioning. So I would try to save it, and in this case, I would consider what I mentioned before. If you have the patient stable, you can open up the gastric colic omentum and free up the left renal artery, and then have it ready to anastomose, just a single anastomosis to the left renal artery distal to the area of occlusion. Apparently, in this case, it's at the origin of the left renal artery, but I would try to save the kidney. There's no need to remove it with a patient who is stable and the kidney looks to be largely intact. So it seems to be salvageable. So and if need be, if you needed the vascular consultants or the vascular surgeon consultants or the nephrologists, you certainly have time to call them in without having to make a decision to do a nephrectomy right away. Since the abdomen is open, the patient's stable, not hypotensive, not hypothermic, and you don't need to get her off the table immediately, I would consider doing that.
Thank you, Dr. Antrak. Dr. Burke, your comment?
Yeah, this is an interesting case. Obviously worried about the kidney, but it sounded like there was a mural thrombus in the aorta, so I'd be concerned about an aortic injury as well. I think since you're there at this point in the operating room, I think you would need to explore the hematoma and get a look at the aorta, do a mesenteric rotation and look at that whole area.
Okay, thank you, Dr. Burke. Dr. Calderon?
Well, as always, it all depends on the hemodynamic stability and the resource available. If the patient is unstable, I would just remove the kidney. But this patient is stable, so I would do the best to try to save this kidney. I don't have an interventional radiology available to make any endovascular exploration or maneuvers to save. So if I have available, I will have available a urologist or vascular surgeon to try to give me a hand with a case like this. Well, to try me to make a decision, what can we do to repair the vascular injury or to just remove the kidney? Yes, I would consult with a vascular surgeon and a urologist if I have them available. But if I don't have interventional radiology, I would explore the kidney. Thank you.
Thank you, Dr. Calderon. Dr. Ramos, any comments?
I agree with Dr. Calderon. I wouldn't take the kidney out, and I will talk to the vascular surgeon to see if there's a way we can solve this endovascular.
Thank you, Dr. Ramos. Dr. Pilasi, any comment?
Yeah, I think it should be considered how long the warm ischemia has been there, because kidneys are particularly not very good at tolerating very long warm ischemia. So depending on that, if there's something that you can do about that kidney. I agree, there's no damage control situation at this point. Patient is stable, has recovered just with some fluid, and has been stable throughout. So therefore, I agree there's no criteria for damage control. And I also would consider consulting interventional radiology for the if there's something that can be done, again considering the length of the warm ischemia, and also to comment about that clot in the aorta. I think that also needs to be addressed at some point. If they feel that that patient probably doesn't need any further treatment but anticoagulation, then probably I would remove the kidney then.
Thank you, Dr. Pilase. I think we have Dr. Shohiro Kobe from Japan. Dr. Kobe, can you hear us? No. Okay, anyone else? Any other comment? Dr. Gusmao, we go back to you.
Okay. So what we decided to do was what some of the doctors said. We decided to discuss the case with the vascular surgeon. And since the patient was stable in hemodynamic, he indicated the proceedment in the hemodynamic sector immediately. So yeah, the patient went to the hemodynamic sector of the hospital.
Let me talk about this. In this moment, we discussed the case, the case with the vascular surgeon. In our hospital, is the vascular surgeon that do the hemodynamics procedures. It's not the radiologist, interventional radiologist does the procedures too. But in this case, we discussed with the vascular surgeon, and we discussed if the conditions of the patient was ideal, the stability was okay, and the risk versus the benefit of the procedure. We know that there was a risk that unclot any vessel that is injured, and we according that if the patient becomes unstable, we put the patient again in the operation room and we do the nephrectomy if it was necessary. So the trauma surgeon is still with the patient, with the vascular surgeon to make the procedure in the hemodynamic switch. Okay.
So here is the angiography. You can see a damage, like
No. See that in the first moment, he didn't see any injury in the arterial, in the renal artery. But when he changed the position, and makes some maneuvers, he can identify the injury.
Here.
Okay. And this is the report of the vascular surgeon.
Yeah, there was a filling defect in the proximal third of the left renal artery, compatible with traumatic dissection. The right kidney was okay, and they implant a stent to stabilize the intimal flap of the left renal artery. After the arteriography, the care was dual aggregation with AS and clopidogrel. We maintain the urinary catheter, and we should do a 48 hours CT scan control. And then the patient went to the ICU. And then we're gonna show the 48 hours control CT. So now the left kidney is okay. And after all that, the acetabular fracture was correct by the orthopedic and after the hemodynamic procedure, and 15 days after the hemodynamic procedure, and the patient was discharged after 2 days. Now the patient is in the third DPO in a good condition. All the intake and eliminations are okay. She's using rivaroxaban 20 milligrams for 90 days, and she continues in a outpatient follow-up with 90 days renal CT assistant. So the conclusion of this case is that time is everything in the trauma care. It's like the definite key. And adequate initial assessment management can stabilize the patient and allow a better diagnosis, better treatment and decision. And hybrid treatment is the best option in select case. And a trauma center is always the best place to treat a several injured patient. So that was our conclusion.
Thank you, Dr. Gusmao. Would you like to go to final comments? Dr. Antras, would you like to make any final comment?
Yes. So the jejunal injury, was that a perforation or a subserosal hematoma, or what? It just required some oversewing, or what was the exact injury to the jejunum? You're muted, Dr. Caselli.
Dr. Caselli, we cannot hear you.
Wait. Okay, there was 2 centimeters, 2 or 3 centimeters injury, a perforation in the jejunum.
Yeah. Right. Okay. Well done. I mean, the kidney functioned, and the only thing I would say is, if you're worried about the warm ischemia, and I don't know how long the delay from the injury until the angiogram, but that wasn't too long. But in general, with a stable patient, if you're worried about saving the kidney, which is appropriate in a stable patient that responded and remained stable, then I think, and it's taken me a while of hearing Dr. Fraga's cases to change my thinking, but I was initially very critical about not operating on young women that have, grade 3 or 4 splenic lacerations, but he's been successful at it. And in this case, worried about saving the kidney, I would have gone to angiography first. And I would certainly, and I empathize with our colleague from London, I would be sweating it out for a few days, having not done a laparotomy, but I would watch closely. And then even with a perforation, you can get by 10 or 12 hours, or even the first 24 hours and fix it then, but knowing that you saved the kidney. And if there was a lot of worry about the perforation, I would maybe fix the kidney first, take control of the spleen, and then, do a laparotomy, run the bowel or laparoscopy, find the perforation and repair it. Probably you can even do it laparoscopically for people that are good at it. But a very, very nice case, and well handled.
Thank you, Dr. Antrak. Dr. Burke, any final comment?
Yeah, the same. That was handled very well, and a great job on the stenting.
Thank you, Dr. Burke. Dr. Pilasi, any comment? Dr. Calderon, any final comments?
Tough case, nicely managed by the team. Thank you for sharing. Well, I always stress my boss that interventional radiologists or vascular surgeons who do these endovascular interventions are very life savings. They're very important, even when we have a spleen or liver injury that we want to manage non-operatively. These maneuvers are very important to find out active bleeding, do embolization, endocols, things like that. Thank you for sharing the case. Very illustrative.
Thank you, Dr. Calderon. Dr. Pilasi, any final comment?
Yes, thank you for the presentation, very well documented. And I agree with my colleagues, and mainly with what I take from this case is that it's been tailored to the resources you have and the patient itself. So it's no one size fits all in this one. I think it's reassuring and very well managed. So congratulations.
Thank you, Doctor. Dr. Ramos, any final comments?
Great case, and it's amazing the difference between a patient being treated in a trauma center and a normal general hospital. Very good case. Congratulations.
Thank you, Dr. Ramos. Dr. Neiman, any final comments? from Miami?
No, thank you very much. It was very interesting.
Thank you. Okay, thank you, Dr. Caselli and Dr. Gusmao. Let me share the screen with the code, the CME code, for a second. Perfect. We will not have a session on July 4th, so our next session will be the following week, okay?
Okay.
Thank you, Dr. Caselli and Dr. Gusmao, for the presentation and sharing your case.
Thank you.
Thank you. Thank you very much.